remind each other to do that, and we'll get it on our tape. Appreciate your help with that. So questions and comments?
Yeah, I have a question regarding the security. If a patient says that they don't want their information recorded or distributed through that system, and they're just excluded, is there going to be steps taken to limit who gets access within your application so that only a physician of record or a healthcare provider of record would have access to that information?
Okay.
Are you tightening up that?
Okay. Yeah. So the question is, are there steps being taken to tighten up the security aspect of our network to make sure that only the physician of record gets access to a particular patient's record, recognizing the fact that anyone who has not consented to have their record included is not included in the network. Is that the question? Okay. Well, the first part of the answer is we take the point of view that we want to make this into as useful a system as possible for the providers, for the doctors, the nurses, the therapists who provide health care to our kids. We have not limited access to only the physician of record. We have made it available to anyone within the hospital who would normally have access to paper records, and we remind them. The very first screen that comes up when you log on is a reminder of their professional responsibility to look only at the records of their own patients or the records of patients for whom they have some responsibility. And we do have, as I indicated, the log that would make sure that is not violated. People are reminded periodically that violation of that rule can bring severe consequences. So that's the way we are operating it. The second answer is that it's entirely possible. The software would allow us to impose something like 7 different levels of security, so that only the physician of record or only such and such people could get access to such and such records. The reason we have shied away from implementing that kind of a security system is that we want to get people to use it as opposed to become frustrated with it. Every time you impose more rules and regulations, more restrictions on a system, the more you're putting at risk the likelihood that people are going to use the system. We do periodic spot checks, regular spot checks of patient records. We have not identified a single abuse of the system so far, and we've been operating for 2 years now. This is a question that is entirely reasonable, and it is entirely possible that sometime in the future we may have to impose more levels of security. As Pat can explain, certainly the system is designed in such a way that you can restrict access in any one of many ways. But our view is that we don't want to restrict it any more than is absolutely necessary to protect the record, and we figure that if we protect it as much as we protect the paper record, and then some, as I indicated, that's probably quite sufficient for now. Pat, do you want to add anything?
No, I think you've done well.
Do you have any, can you give us any information on like sort of objective benefits, and then on the other side of the coin, the costs? I mean, I think most of us would agree it's a great thing to have. 20 years seems like a long wait, but how do you sell this to, for example, let's say a chain of 10 hospitals in Texas, for example? How do you do the numbers?
The question is, how do you measure the benefits of a system such as this? While instinctively you may think that this is a good thing and it's helpful, how can you translate that into measurable ways of proving to hospital administrators that this is something they should invest in. Is that fair enough? Well, good question, and it's not easy, let me tell you. Essentially, people react to the system in a very positive way. They look at it and they sort of say, gee whiz, this is terrific. This should be part of the basic infrastructure of the province's health system. And I couldn't disagree with that at all. Currently, the Ontario government has a policy of not funding any networks at all, whether they are children's networks or rehab networks or cardiac networks or cancer networks. Cancer actually is an exception. But they're certainly not funding infrastructure for those networks. So it's been a bit of a battle. The provincial government does recognize the value of this. I mean, after all, they have funded this up to now to a large extent. The funding has come from two sources: the provincial government and from the hospitals, mainly the Hospital for Sick Children. And both the government and the hospitals have seen the intrinsic value of having this kind of a network and making available this kind of data. There is no hard evidence yet as to the actual dollars and cents of savings that this might bring about, and I would argue that there probably won't be any. We can probably develop all kinds of economic models that will show a decrease of 5% or 10% in the number of tests done, and translate that somehow into dollars and cents. You can do that, but I don't think it's worth it. I think the real value of it is in the improved access to good quality care. Typically, the hospitals that have the vision or who have the desire to provide top-tier care to their patients are the ones that are going to invest in this. And that's very hard to translate into dollars and cents. In some areas of the province, it also helps with recruitment and retention issues, where it's very difficult to find physicians to go and work in certain rural and northern hospitals. This is an additional tool that the hospitals can use to make it easier for the physicians who do go to those communities to provide the best possible care, because they can share the data, the information and knowledge with their colleagues in the tertiary care centers. So far we have only got 2 tertiary care centers, Bloorview Macmillan and Sick Kids. We are hoping to add 2 of the other leading centers, London and Ottawa, for very specific needs that they have, namely cardiac surgery, where all the cardiac surgery is being transferred to Sick Kids. So what you're going to have will be patients who are patients of, let's say, the Ottawa Hospital, the Ottawa Children's Hospital, the Children's Hospital of Eastern Ontario, or the Children's Hospital of Western Ontario in London, but they get transferred to Toronto for the surgery. And then they come back to Ottawa or London, and it would be nice for the physicians, the cardiologists in London or Ottawa to see what happened while their patient was in Toronto. And that will be possible using this. It's not possible today. Dominic, do you want to...
Is there a concept of ownership of the individual parts of the record, or does the ownership end up in the hands of the...
The question is there a concept of ownership with regard to the individual record? Is it with eCHN or with the individual hospital, right? Okay. The answer is we don't really address it directly. We address it indirectly. Basically, there's another issue which you didn't allude to, or maybe you meant to, and that is, what about the patient? Does the patient own the record? Who really owns the record? We don't really take a stand on that. We are quite agnostic on that. We sort of say, well, the record may be owned by the patient, or the record may be owned by the institution that created it. In any case, it is not owned by eCHN. We are simply a secondary custodian of that record. The primary custodian is the institution that created it. It is responsible for maintaining it and protecting it. We simply share in the custody of that data and make it available to other users who could benefit from sharing that data. But we don't update their data. We don't mess with their data. It remains in their custody, and we simply share it. Sorry?
I find it very interesting the potential for the universality and comprehensiveness of this. But I'm wondering if it's a reality yet. In other words, in some of your figures, I think you showed the physician's, what am I trying to say, the GP's office, the tiny little building.
Yeah.
Is it actually being used in locations like that, or is it only being used in large institutions?
The question is, where is the system being used? Is it only being used in large institutions, or is it being used in individual physicians' offices? The answer is it's used in both. And let me tell you how it's being used. In the case of institutional users, who are the institutional users? It's the doctors, the nurses, the therapists, who have to look after the patient while the patient is in their care at their institution. The physicians who have access from their own offices are typically physicians who are following the progress of their patient and who want to know for their own benefit, because they are the primary caregiver for that patient, what's going on in the institution, what are the latest results, what are the latest notes. And secondly, and just as importantly, they want to be able to tell the parents, to keep the parents abreast of what's happening with their child. So in a very big way, the office user is a very important user. Now, we can't update the record from the office, if you were going to ask that question. But what they can do is they can simply follow the patient's record as it progresses through the hospital system. The only way they can add something is through a dictated note. If they have privileges at one of our member institutions, they can add a note, which then becomes part of the record of that hospital, and therefore it becomes part of the overall record of that patient.
What you've shown us is very impressive. You've pulled together a lot of different parts of the hospital, and I'm wondering, when did you start this initiative? Is this something that has only been the last 2 years, or did you start this 10 years ago and been slowly building up to a point where you have this demonstration as you showed it to us today?
The question is, when did we start this project? Has it been just in the last 2 years? Have we been working on it for the last 10 years? How long did it take us to get to where we are? Fair enough. The project started, I guess, about 4.5 years ago. It started with a joint inquiry, as it were, by IBM and the Hospital for Sick Children. Some people at the Hospital for Sick Children had the vision for some sort of a system along these lines, but they didn't know exactly what it was going to look like. They sort of had an idea of what they were looking for, but they didn't know how to do it or what it was going to be like. And so even before they approached IBM, they did a survey of the existing vendor systems in North America that might respond to this need. They found that none existed. The closest they could come was that they found that IBM had something with a group of hospitals in St. Louis, Missouri. And so they visited that, and they were impressed that it was something that they could build on, they could adapt to Canadian and pediatric needs. So then they called in IBM, and they made a deal whereby they would explore the possibilities, and they concluded fairly quickly, within about a year or so, that this was the way to go, that this would do what people were aiming to do. And remember, at the same time, there were all kinds of other people running around sort of trying to figure out what to do. And there still are today, as you can imagine, trying to figure out how do you create an integrated, shared electronic health record for the population. They came to the conclusion about 4 years ago that this was the way to go. They started to build it. We actually started to populate the database with real consented data about 15 months before we went live. On July 1st, 1999, we started getting consent from people in the initial 5 member institutions. And then on October 30th, 2000, we went live with the original 5, and then we've added 3 more since then. So it's been kind of a long process, but not as long as one might have thought. And we are certainly still the only functioning, operating, shared, integrated electronic health record in Canada.
Questions over here?
I noticed on one of your early slides, one of the organizations that listed was Innovator Healthcare, and I'm wondering to what extent and in what manner you've been able to integrate information from the community sector.
The question is, we have St. Elizabeth Healthcare as one of our member organizations. To what extent have we been able to integrate the community sector into our system? Fair enough. The answer is not as much as we would like. St. Eliz have been a terrific partner. What they provide are the care plans for their patients. And the care plans go straight into the record so that they are available to anyone who will be looking after those children in the future. Typically, kids who require home care often end up having to go back to perhaps a rehab facility, perhaps a chronic care facility, maybe the emergency room of an acute care hospital. So the home care plan is quite a relevant part of that record. We are currently working on bringing in the community care access centers. As those of you who know how the Ontario home care and long-term care system works, it all is funneled through something called the Community Care Access Center. And St. Elizabeth Healthcare is one of the home nursing agencies that provides home care to children and adults throughout the province of Ontario. If and when we add the CCACs to the system, of course the home care sector is going to have a much bigger representation within the overall record. And I guess I'll just mention it is probably more useful to the home care providers to have the record from the acute care and chronic care hospitals than the other way around. But that's not to say that there isn't a two-way street, and there's value in having a complete record, and the complete record includes the home care plans.
Pat, if I might, I'd ask you a question. Can you give us an idea about how this is done, the technology that underlies it all, and how you're going about doing it?
Sure. Actually, the last 2 questions had a continuing theme, and so I wanted to expand on that first before I get to your question. And if I forget it, please remind me of your renewal. The question that came over on this side was whether or not physicians' offices could contribute data as well as access the data that's obviously being generated through traditional sources such as in hospitals. And over here we had a question about home health care agencies. When we implemented the system in Toronto with the eCHN network, a decision was made to base all input on a data standard that's used within the healthcare industry. Letters you saw earlier on a chart called HL7. Now, that has some good points to it and some disadvantages. Obviously, the benefit is that it makes it much easier for information to flow into a computerized system if it's using a standard messaging format. However, those guys who have to contribute data have to have the capacity to build a message in this format. And so clearly, a mom-and-pop clinic, an individual physician, a home nursing agency who have very, very limited funds and limited technology clearly would have an enormous challenge trying to also deliver information through an advanced messaging standard. We have implementations of this solution across the country, and some of those implementations recognize that fact, and so it is possible and conceivable if you have some kind of information in some computerized form, whether it be in a word processor or in a physician practice management system, etc. As long as we can get it into our system, we can actually include it in the record. The other thing that we were doing recently out West is a client of ours asked us to acknowledge the fact that there is still an awful lot of paper being generated and very important documents. Cancer is an example. There are certain therapies that are administered, and some of them are toxic, and records have to be made of those, and those are usually handwritten. How do we get that into the system? And so we actually had to address that by permitting scanned or document images or other kinds of images to also get included into the record. And we recognize fully that as we go through the future, we want to include as much information as possible to make it valuable. We have to recognize that not everybody is advanced technologically and can contribute data in that manner. Now, your question, Dominic, was what technologies did we use to get there? There are basically 4 problems that we're faced with when we try to deal with information coming from multiple sources. One of them is that if I have Hospital A and Clinic B, and they're both using different technology, different formats, almost certainly they're using different identifiers as well. And so how do I know that John Smith and Johnny Smith and Jay Smith are all the same person and this information is theirs? You can understand that health record custodians within individual facilities struggle to make sure of the accuracy and purity and appropriateness of information within a folder. When I've got information coming from multiple sources, I have to be extremely sure, with high confidence, that that information is truly from Jay Smith, who is also known as John Smith, who is also known as Johnny Smith. And so we had to build a technology that used a variety of different identifiers and invoked some logic that allowed us to pass some tests and some logic and some weighting factors and some other decisions to try to get to a degree of confidence that with 4 or 5 different elements, I can be reasonably sure that with a surname, a first name, a date of birth, perhaps a health insurance number, other elements, that yes, this is probably that person. And so that was one piece of technology that we had to build, which is a vital first step. The other thing that we had to do, of course, is receive information, and as you heard me mention a second ago, earlier what we did was build it using an industry standard, such as an HL7 messaging. But we're now being faced with the challenge of having to add to that for those people who can't contribute in that way. But as standardization becomes more advanced, that will be facilitated. We also, yes ma'am?
And I was going to ask about if physicians, the OMA is holding up progress as well in their, I think it's the PKI certificate, in allowing the access. Is that it?
The question is what the OMA, the Ontario Medical Association, and physicians groups are looking at using certain technological innovations in order to make sure that they can properly identify themselves and have secure access to information through a network, and the use of PKI, the public key infrastructure technologies. There are actually initiatives that are being moved forward on by the Ontario government and by other jurisdictions across Canada that are asking for inclusion of things like PKIs that allow for secure transport of confidential information through public internet systems or semi-public internet systems, as well as the obvious one we've heard here, which was a private network. There's nothing in our technology that prevents you from using any of those transport mechanisms, but clearly the transport itself needs to be as secure as possible. And so there has to be a demonstrated degree of comfort that even these proposed technologies actually deliver on the absolute and total security. And so there's a lot of talk about it, and there's certainly an intent to move in that direction. And as they become more stable and more mature, you will see them actually implemented. And there are some pilots that are about to be initiated in that arena.
Before we move on, a little further about the technology.
Sure.
You have individual systems. How do they communicate that information? Do you prompt them to do it? How do you get a laboratory information system to send you that record?
Super question. What happens is that I'm going to give you a phrase that you've probably heard before, but it's an important concept in an aggregate record, and it's called source of truth. And that means that when the Hospital for Sick Children's or other contributors, such as Aurelia Soldiers Memorial, etc., went out and bought their laboratory information system, this is a computer application dedicated to dealing with the laboratory part of the operation of the hospital. They investigated that for years. They spent a lot of money. They went and got it implemented to suit their needs. And they've also put a lot of money into making sure that the results are verified and get stored in the system accurately and are checked. We call that a source of truth because there's a degree of rigor, there's a degree of discipline, and there's a control in place for that system. We had no intention whatsoever of duplicating that because it already exists and it already works well. So what we do is we actually seek out an additional copy of information the moment it's being generated at the source system. And so therefore, as a laboratory system generates a message, if it's appropriate to do so, it sends us a copy as well. One of the things that you heard is that it has to be consented. It has to be a child under 19 years of age, and any of another variety of factors. The other thing is that the information has to be put into a format that we can understand. And sometimes there are some business rules or logic around whether it's even appropriate to receive it. For those of you who may or may not have experience with laboratory systems, sometimes results are pumped out as an interim or urgent. You may have heard even on TV shows stat orders where I need to know that result within the next short period of time. Is it necessarily valuable or interesting to persist that temporary quick result, or would it be better to wait for the final official result, which is more complete and vetted? And so what we can do as well is invoke filtering and rules that says only accept this information when it meets certain criteria. And obviously things like it's a final result is another one of them. So what we do is we don't ask the systems to do anything they don't do except send us a copy. And there are technologies out there today, middleware interface engines, that allow you to send out a copy from there into our system as well in an appropriate manner. Originally, and many, many years ago, people were talking about, and still do, talk about fetching information directly from the source systems on demand. And it sounds like a reasonable approach as well. The challenge with that is that you're depending on each of those systems to be up and available the moment you inquire. Also, that they're capable of receiving an external query, which is not always the case, and have all the appropriate mechanisms for transmitting out a result. It also means that if any of the systems have a point of failure, then you have an incomplete record, and sometimes you may not even be aware of that. So that's why we opted, after many, many years of designing, to take a replica of data, only the data we want to persist in a community health record, which is distinct from a facility-based record, and then make it accessible. So that's how we get information in.
Very back.
So if in a hospital we have some system that exists for a couple of years, and on one of the slides you said that you are not forcing the hospital to change for something for new devices, and so how can you make the existing system to produce these messages?
We try to make it as painless as possible. I'm sorry. The question is, how can we receive information from legacy systems, that is, systems that have already existed? And let's use our lab example, because that's a good one. Let's say my lab system in my house was 5 years old. The guys down the street could be 10 years old, whatever. How on earth did we get that information that it wasn't originally designed to be exported out into some other environment? First of all, this is actually, you've raised one of the most important elements in putting together a health information network. Is it's not necessarily installing the computer and the software to receive the information. It's getting the systems that are out there that are contributing ready to send. That is probably the biggest time factor and the biggest effort. And so some systems, if they're fairly modern, are actually aware of the fact that other systems want information from them, and therefore are ready to go today with the appropriate command to send a copy outside of their environment. Other systems, with a little bit of effort, can be allowed to be connected to another piece of software, usually on a different computer. This is often called middleware or an interface engine that allows the connection to that application and then has all of the intelligence within its own box to now route it to all of the recipients who could or should use it and do any massaging of the information. In very old systems, sometimes the only way to do it is to go find the guy who wrote the program, if he's still around and if he still remembers and still has the documentation, and actually break open the software and try to build exits and special routines that allow us to communicate. Those do happen. We do face those. They're the most challenging of all. But every one of those examples we've overcome and been successful with.
Question in the back here.
Yes, ma'am.
Yes. Is it a view-only system so the receivers can only view it, they can't print a copy?
First of all, view and print, I don't distinguish terribly. So the answer is yes, we do allow print, and we do have a security mechanism that can restrict who and when can print what. Because clearly you don't want ad hoc printing of clinical information to those who shouldn't be doing so, because that breaches your security mechanism. So we do have that. I'm going to answer a slightly additional question, which I think might be implied in yours, which is, what happens if you want to enter data into the system? As a general rule, and the way we opted at the eCHN environment, is that we wanted the source of truth, if I said that right, sources of truth, to be the contributors of data. And in fact, we opted on the HL7 standard to force a certain discipline and rigor. However, we do support the input of certain information into the system, recognizing an example that was raised earlier, is if I've got Dr. Jones at his own office and he doesn't have a computer system, how does he get his patient into the system, and how can he contribute data? And so we have to allow for the addition of individuals to get them registered and known to the system. We have to be able to enter in episodes of care or encounters. But from a clinical point of view, if you're going to give me lab data, if you're going to give me other kinds of clinical data, we prefer it to come from a source of truth which already has all of the capability. However, we also have the ability to take in documents, and they can be either scanned or they can be used through the word processor or whatever. If you want to actually sit down and type it in today, we don't allow that because that hasn't been considered a desirable thing to do. And also, most physicians don't have the time to re-enter information into this system from their own. What works out best is at some point in time they have an in-house system that creates these reports, and then we can get a copy of it when that's ready to transmit.
Question?
Two related points. One is, since you have a copy of the data, what measures are taken to ensure that the copy is complete and accurate, other than the obvious step of getting the message and understanding it correctly the first time? And the related one is, I guess maybe you've already answered this, but it's just that are any of the institutions asking you to be the only repository for the information? In other words, is anybody asking you yet, well, since you're taking this information, we're not going to keep a copy of it, we're just going to rely on your copy?
I'm sorry, I forgot the first question.
Sorry, so the first one is, how do you audit the...
Oh yeah, the completeness of the record. Yeah.
It's accurate and complete?
You're going to hear me say it one more time. I don't want to be a source of truth, although you can ask me to be if you so choose. Therefore, I prefer you to pass on to me information that is appropriate, and I will take it. I will perform edit checking that not only says it conforms to a particular format, but absence or presence of data where it should be is already there. I'll make sure that I don't have a month 13 and things like that, so we can do some fairly routine data checking. We also have a very, very complex and sophisticated engine that Andrew referred to earlier called the Medical Entities Dictionary. And it doesn't handle data, it handles medical concepts. So it understands a concept, which we've termed an event life cycle, which may be something like a test, a white blood cell test. And therefore, it has enough intelligence as it takes the data in to understand whether that record is complete, because I would expect the following 3 elements to form this message. If it's not final, I won't accept it. And so there's a direct example of how it's not passing the test. Clearly, though, my system or any system could not be asked to actually say, is this a valid medical result? That is asking far too much out of a receptacle of computerized data. That's why we try to impose that role on the source of truth, and even there it can be challenging. Most of those systems that are providing clinical results for which diagnosis and care decisions are being based on are often hand-checked and signed off by hand, in addition to just simply being run through a computer. And so, I can't do anything unless I build the most intelligent system in the world with the most broadest knowledge base to be able to say whether or not something fits where it belongs. I still can never interpret whether or not the result makes sense. If it looks abnormal, go back to your source system and verify.
There's a question in the very back, and I'll go to you next. So,
which one? Sorry.
I just was wondering, well, you mentioned twice now about middleware.
Yes, sir.
Now, I'm wondering if you can provide maybe a little bit more light there. Like, is part of your solution in some cases plugging some middleware into an institution that maybe understands HL7 and can redirect accordingly? Or?
Originally, that was our question. Sorry?
Repeat the question.
I'm sorry. I'm obviously not experienced with this kind of thing. The question was, are you, talking to me as representing the vendor, are you providing the middleware or the interface capability so that you can receive HL7 messages from other legacy systems? Originally, we designed it to do that, and we do have an interface engine under the covers of the application. However, the vast majority of our customers are in or have already gone through at least one wave of introducing interface engine technology within their own environments. Because, as Andrew alluded to earlier, we have a challenge even within a facility sharing data between one system and another, the lab and the admitting system as an example. So therefore, we were being duplicitous, and we were reproducing what they already had, and in fact, they didn't necessarily approve of our choice of technology versus what they might have gotten. So what we've done is we've externalized that role, and we expect to talk to some mechanism that can deliver a message to me in a particular format over TCP/IP in HL7. How it gets to me could be directly from a modern application or mediated through an interface engine or a point-to-point interface or whatever kind is appropriate or gets us there. I, in turn, take that, and obviously I decompose the HL7 format and take the data and internally process it within the application. And I do have the capacity to perform that role, but we recommend normally to have it outside. Because it's pervasive in the marketplace, and it usually is performing numerous roles besides just ours.
You're utilizing like a single repository approach?
Yes.
Where are you doing your filtering for your messaging that's coming in? Is it done at the source site, or are you doing it all at your central site?
It's done before it's delivered to me.
It's done
in the case of the eCHN network, they are doing the filtering before they deliver to me. They have had lots of experience. They have a very sophisticated IT department, and they have a very robust interface engine environment today. And so they are having that and the sending systems perform the filtering. And whenever you experience some hiccups and some errors and being flooded with, let's say, perhaps accidentally unconsented data, etc., then you start thinking about perhaps putting layers or waves or walls of interface engines in front of them to try to give you as much protection as possible. So as you evolve into a real true clinical longitudinal record, you want the data to be as clean as possible, and so you put in as many filters as you want. I just perform the appropriateness of the message content, which is it populated correctly and is it populated in the mandatory areas and that kind of thing. But the actual filtering is done before it gets to the front door.
No. So one now, that was you. Okay, you
I have two questions.
Yes, ma'am.
First of all, has anyone actually used your system for the research purposes?
Not at this point, but everybody, I'm sorry, has anybody ever used our system for research purposes? Clearly, if you're starting to receive information from multiple sources across a community, a geography, or what might be termed an integrated delivery system of some kind, like a region or a district or a province, there's clearly an enormous amount of valuable information for population health studies and other things. And clearly, as data is being aggregated and received into the repository, one would want to mine that information in the future. Everybody we talk to recognizes that, not only for clinical analysis, but for utilization analysis as well. Clearly, you have to start building up enough data to perform those roles, but the data is being collected, and so somewhere in the future it can and should be created.
Can I just
And my second
add
question is, do you have any information or have you done any studies on if and how physicians are actually using your system, for example, in the hospital? Do they actually turn to your system first to gather information? Do they turn to the paper documents, or do they turn to the legacy system?
Okay, I'm going to let Andrew answer, first of all, your first question, which he wants to answer, and then secondly, he's also best to answer the second question.
Thanks. Just a footnote to the research question. I just wanted to say something that may be anathema to say in a university setting. But my approach to that question of research is to the researchers, and God knows we've got thousands of them at say Kids and at the University of Toronto. If you want to do research, build your own database. This database was built specifically for clinical purposes. We obtained consent on the basis that we're going to use it for clinical purposes only. We can't turn around and then change the rules after the parents or the patients have already consented to sharing the data for clinical purposes and sort of say, well, sorry, we changed our mind, now we're going to anonymize it and use it for research purposes. So I think that it's entirely possible to use this data for research purposes, but we have no intention of allowing that to happen. Not within the foreseeable future, and not without significant changes in the way we administer the consent procedure. As to your second question with regard to how do physicians use the system, it's basically used as a secondary system because they are used to the systems that they had before this. Slowly and surely, some of our champion users are starting to recognize that in fact they can use the system as their primary system because in fact it contains the same data. But that's sort of a long, hard road to follow before people will realize that in fact they don't have to log on to two different systems because they can just get the same stuff from this one. And in fact this one has more data than any one of the individual other systems. Certainly, as I indicated, the physicians who view the data from their offices use it as their only way of following the progress of their patients, because at home or in their own offices there is no other access. Within the hospital, they have a choice of using ours or using the various legacy systems, and typically they use ours as the secondary one.
I think we have time for one more question, and the figure is that.
That was answered. I wanted to hear the experience of the healthcare provider who utilizes the system. I'm thinking of the sheer volume of information that they just don't have access to right now. I don't think my GP would really look at all this information. I'm just coming out very quickly. I'm trying to imagine him having access to all this information.
Okay, the question is the volume of the information that is available to people like GPs and other physicians. Are they actually going to bother to view the information that is available through this system? The answer is probably some of them will and others won't. And even the ones who will probably be quite selective about it. What will happen is they will look at the data on their sickest patients, on their most complex cases. The cancer patient who may also be suffering from epilepsy, who ends up in the emergency room 4 or 5 times a year with a very worried parent who needs to be reassured all the time. I had a very reassuring email message from one of our physicians over the weekend about a specific case of a patient whom he's been following, who is precisely, that was the description. This is a little boy who has both has had cancer and epilepsy, and whose progress he's been following. This physician has been following regularly, both from the hospital and from his office, because of the need to communicate with the parent and the need to know what needs to be done next. So it's kind of selective. I suspect that as more information is available, as more patients are in the system, it will be used more and more.
Sure. Just to add another point to that, is that I think it's unrealistic to expect any healthcare provider to go to a computer screen, at least in the near future, for their daily activity. First of all, the completeness of the record is paramount, and if it isn't 100% totally complete, they will look at it as an adjunctive aid for information, but not as a primary aid. And so therefore, our experience right now is that most healthcare providers are not looking to this thing to be the complete record. That's not what they want out of it. What they want is access to a particular piece of information they're interested in when you present yourself in their office. And they want to get at it in a hurry. And they don't want to have to navigate through 42 button pushes and awkward design. They want to be able to get it. And so what we did was we reconstructed this thing. Our traditional thinking for the last 30 years in healthcare informatics is to be transactional. We then said, what do you want, physicians? And we focus grouped an awful lot of physicians and healthcare providers. And they said, I don't think in terms of episodes of care, for instance. It's not something that I work with. I don't think in terms of encounters. You may, in the U.S. certainly they do for billing purposes or for whatever other reason. However, they think in terms of lab results. They think in terms of radiology reports or in terms of progress notes or discharge summaries or operative notes. And so that's why we reconstructed it the way they asked us to. So they say, if I need to get to that discharge summary, I want to get at it in a hurry. And obviously the last one in is the first one that's displayed. That's the one I'm probably most interested in. So this is a tool that provides a little more one-stop shopping to get at healthcare information, that vital little piece that you need. If I'm in an emergency room, and I'm at sick kids in the emergency room, and I happen to have this child that Andrew's just mentioned present, and I happen to see, oh yeah, you were in last week, and oh yeah, you had the following abnormal result in your test. I may not look at anything else in your record. There may be lots and lots of information, but that was more useful than not knowing about it at that time. And so that's basically where we think the value is today. Clearly long term, and I think we all intuitively understand, that an absolute cradle-to-grave record of total completeness is something that is interesting. But I hate to be the physician that has to crawl through millions of pieces of data from a lifetime just to get at what I want, which is usually the most recent stuff and the most proven. So that's really, so I would say characterize it as, even though it's complete, and you as the consumer and the healthcare patient understand you want it to be complete for your physician, all he wants is a particular piece of information.
One last one. Quick one.
Sure.
Well, we have to be very quick because the board has their time. So.
Do you store image data since you only store like plain text data? How do you view the image?
In the case of the eCHN system, what they opted for is they had already made a significant investment in a decision in an information system, picture archiving communication system, or PACS, or teleradiology, which is conveying diagnostic images from different modalities like CT/MR and radiographs, etc. That already existed. Why duplicate that? So what we did in the example you saw that Andrew showed was I do have the report through my system. I have a little icon that says there's an associated image. All that is the URL. All it is the address to their server, and it goes and launches their application. And it gives them all the tools, all the viewing, all of the library, and all of the image manipulation capable. For those who want us to store the image, yes, we can do it as well. But I think this is actually a better way to go because most places are investing for diagnostic purposes in those kinds of technologies. Why not coexist?
All right, well, this has been quite a presentation. It's been an exciting one for myself. I've really enjoyed it. I guess what I appreciated the most as you were talking about how you did the implementation was the common sense approach to your decision making. It seems to me that there have been a number of instances where you said, well, this is a stumbling block for many other systems that are trying to be implemented, but you've found a way of at least implementing it in a very useful sort of way and getting around that stumbling block. So I really applaud you on that. And maybe all of us can join me in applauding our two speakers.